Okay, thank you. So I have one interactive question. So if you guys want to scan this with your phones so that you can answer it on your phone, I'm going to ask the question at the beginning and then again the same exact question at the end just to see if things change. There is no necessarily wrong or right answer. You guys got it? You good? All right, I'll wait. While you guys are doing this, I'll give you a little bit of background. As one of the directors of this conference, I get to choose what topic I speak about and how long I talk for. And for some reason, I thought a 30-minute talk on the two most potent therapies for both obesity and diabetes and their related conditions would be possible. And the truth is, I'm going to talk really fast to try to make it work. The videos end up being put on Vimeo, ViewMedi, maybe even on YouTube, and you can just slow it down to like 0.5 if I speak too quickly and you want to remember something. Are you guys ready? Okay, here's my disclosures. So let's start with our case. So this is Diane. She's 44 years old. She has high blood pressure. She's on an ACE inhibitor, prediabetes, and high cholesterol. She comes to see me in a request to lose weight. She's struggled since her early 20s with this yo-yo weight pattern, has tried multiple things without long-term success, every fad you can think of, even evidence-based treatments. She's done Weight Watchers, counting calories, even HCG injections, phentermine. Nothing seemed to work long-term. She's pretty active. She's a nurse at Scripps. She has their HMO health plan. She's 5'3", 205 pounds, and her BMI is 36.3. I realized this morning that I might be describing people that you know or even people in this room. And if that is true, it was completely unintentional. This is a made-up case. But I wanted you guys to feel a little bit of a relationship to it because it's not just our patients that we're concerned about when it comes to weight and obesity, but it's ourselves, right? So I wanted you guys to be like, oh, I'd like to know my own options. So my question for you is, what are we going to do with her? What are our options? And for some reason, you can't see the lowest option, but I'll read them to you. So start a supervised diet. There's one all the way down there too. Start a supervised program with a registered dietitian, with cardio and weight-bearing activity. Start a medication like metformin to help with weight loss and diabetes prevention. Add an injectable medication like semaglutide or tirzepatide. Weight loss medication like phentermine or phentermine topiramate. Or consider bariatric surgery like a gastric bypass or a gastric sleeve. I'll give you like 10 seconds to answer this. Ooh. Do you guys see all of the options on your things? Okay, so the 0% for weight loss medication and 0% for bariatric surgery is not just because it was cut off at the bottom of your screen. You guys, this is amazing. Okay, I love this. So we have 48% that said add an injectable medication, a GLP. 41% said supervised diet and exercise intervention with a dietitian, including weights. 9% said metformin. 0% of people, can you scroll down, said an anti-obesity medication or bariatric surgery. You guys, I just told you she spent her lifetime trying to do diet and exercise and some weight loss medications without long-term success. This is actually like amazing to me. So obviously I'm here to talk about weight loss medications and bariatric surgery, but I'm curious to know how your answer would be different if she had no medical conditions related to her weight, although based on how you guys answered, I don't think that would change anything. If anything, maybe you would be more likely to avoid metformin and just do diet and exercise. What if she was only 24? What if she struggled since she was 5 years old? What if she was 68 or 75 or 80, right? Does that affect your options? What if her BMI was only 32? What if it was 60, right? Would that have changed how you guys answer that? I don't even know if it would have. You guys have like shocked me right now. What if she had type 2 diabetes? That would have changed your answer, right? Maybe some of you are nodding. Okay, we'll see. Like I said, what if it had been concerned since childhood? What if she had Medi-Cal insurance or no insurance? What if she had millions of dollars and said, Dr. Harris, I don't care how much it costs. Give me the best that you've got. I can afford thousands of dollars a month for whatever. What if she says, I could never have weight loss surgery? I know somebody who had surgery and they gained the weight back, or they had complications, absorption issues. What if she said, I only want to lose 10% of my body weight, right? I just feel good 20 pounds lighter. What if she wants to lose 80 pounds, get back to where she was when she was, a college athlete, and wants to lose about 40% of her total body weight? She asks you, I know somebody who's taking this medication. It's something. My aunt's on it. She's lost 50 pounds. I didn't say the brand name, right? You can still get, that's not a conflict, right? She doesn't have diabetes. Will that be approved for weight loss? No, right? We're FDA approval. What if she just wants supplements? I'll put anything natural in, but if it's a prescription, I have to go to CVS to get it, I don't want it, even though that's more FDA regulated and better studied. What if it's compounded and I can get it at my local med spa where I also get my facials and my Botox? I'd be willing to take it for a few months, but I don't want to be on anything long term. My insurance is about to change to Medicare or to a PPO or to a new employer. How does that affect things? And all of these things might seem like really, that's probably not that. These are actually super important questions to ask. So I want you guys to feel like you are going through this interactive process with me almost as though you're a patient. This is what I do every time I see a patient. What if she said, I want to get pregnant in 6 months? She's 44. I could have made her 30. I could have made her 38, but we know fertility declines with age. That's a really important thing. Are these even options for her? So I'm going to talk about obesity, I'm going to talk about how we lose weight, and I'm going to really evaluate the pros and cons of metabolic surgery as well as pharmacotherapy. BMI, just a little bit of background, a reminder, overweight is the BMI of 25 to 29.9. Obesity is categorized as BMI of 30 to 39.9. Severe is greater than 40. These are not perfect tools, but right now this is what tool we are using for coverage for things through insurance, although that is flexible and is probably going to be changing in the future. We know there's a ton of complications of obesity. We know that weight loss improves these complications, both the risk of developing them, such as diabetes prevention, as well as the ability to improve them, such as we're going to have Julio Gutierrez talk about fatty liver disease and MASH, and the percentage of weight loss to improve a lot of these conditions starts around 5%. Certain conditions really require more like 10 to 15% to really see benefit, and some of them, even you get greater benefit above 10 or 15%. So we know that weight loss, intentional, healthy means, I'm not talking about weight loss from something really serious, lowers your risk of metabolic disease, mortality, improves quality of life, improves healthcare costs. I know this so well that I didn't even put a citation on this slide, because I feel so convinced, and it was on the last slide, I guess, right? But how can we best achieve this weight loss, and is the mechanism of that weight loss really important? So whenever I speak, and you guys have probably seen this if you've been here before, I have 5 pillars: diet, exercise, behavioral interventions, medication, and surgery, and that's one thing I was asking you guys about, is like, which of these tools would you start with, right? I am going to be talking about medication and surgery, but where is the difficulty in that? As you guys can see, because of your own thoughts and beliefs, a lot of people don't think that surgery or medications are an option. Patients especially will say to me that they want to do it on their own or do it naturally or not take the easy way out, as though somehow a gastric bypass or an injectable medication like semaglutide or tirzepatide is the easy way out. It's doing it for you, right? Unfortunately, we live in a very unnatural environment, and sometimes unnatural treatments are used for this mismatch in this environment in which we are not evolved to. I love pop culture. I love talking about pop culture because this is where most of my patients are actually getting a lot of their medical information. Right, for better or for worse. It's also done great things. So this is Heidi Montag. She was from the Hills in Laguna Beach, and she was on the cover of Us Weekly recently. This was an online edition. I don't know if this was in stores too. And the headline was, How I Lost 22 Pounds Without Ozempic, okay? Implying that there's something inherently wrong with losing weight with a popular, Hollywood-approved injectable weight loss / diabetes medication, okay? And we're going to come back to this in a little bit. In the next few months, you guys are going to see at the checkout counter at Target and the grocery store, People's How They Did It Half Their Size edition, which they bring out in December because they know people are making New Year's resolutions, right? They know their target audience, okay? This is an article on how they lose half of their body size, not necessarily body weight, and always down below, it was so easy for me to find this. No surgery, no gimmicks, because apparently bariatric surgery is the easy way out and it's a gimmick, right? It's basically you didn't want to put in the hard work, you were too lazy, you didn't have the motivation, you couldn't do it, but these people could do it without having to do that. I don't believe that, by the way. I was kind of joking when I said that. But this is what we think, and this is what we've been raised to think, right? Eat less, move more, you can lose weight, you can keep it off for the rest of your life, right? Is that actually what happens? No, absolutely not. Losing weight is semi-impossible. Okay, we can get it done in the short term, but keeping it off long term is almost impossible. Okay, 95% unlikely to happen. So this is Albert Stunkard. He was a psychiatrist on the East Coast. He was studying in the 1950s, 1960s. He had a long history of research, one of the first people to really pioneer studies in obesity. He had interest in binge eating disorder and weight loss, and he was kind of regarded as one of the first pessimists for long-term weight loss. He came and found, after reviewing all of his data, that most obese persons will not stay in treatment. That's not person first language anymore. Persons with obesity would be person first, so a lot has changed in the last 70 years. But most obese persons will not stay in treatment. Most will not lose weight, and of those who do lose weight, most will regain it. This was 1958. Not much has changed. You put somebody on diet and exercise, they can lose weight in the short term, and the vast majority of it is regained within 1 to 5 years after that weight loss attempt. And you guys all know what I'm talking about, right? This is not shocking to you guys. So here's an old study that showed behavioral modification, diet, or both together results in weight loss in this treatment period, which I believe was 6 months. And then they kind of just wanted to see what happens long term as part of this research study. And you can see the weight comes back by year 5, if not more than starting. Okay? There were no medications involved here. Why is this? Your body does not want to lose weight. Your brain has a set point. Oftentimes, it's the highest weight that you've achieved at some point in your life. And when you lose weight, your brain thinks you're going to starve to death, and it does everything it can to make sure that you stop losing weight and regain it. So it lowers metabolism, and it increases appetite to a point where heroic effort is needed to overcome that, right? This is not you didn't have enough willpower motivation. This is that your body's reflexes are stronger than you are. So to providers and patients, it looks like people lose motivation or willpower, but it's strong internal forces increasing their drive to eat more and lower their metabolic rate, okay? So let's talk about medications and surgeries, because the 3 things on the left-hand side, diet, exercise, and behavioral modifications, working with a therapist, weighing yourself daily, tracking your food intake, what did I tell you? Long-term weight loss, there's a minority of patients who are able to lose 10, 15% of their body weight and keep it off long term. So let's talk about obesity medications. FDA indications is for any person with a BMI of 27 or above with a comorbid condition related to their weight, or a BMI above 30 regardless of weight related, okay? That's not that high. Weight loss medications really help improve adherence to dietary interventions and behavioral interventions. They work by changing what we're eating. The older medications, this was published in 2015 in ADA's journal. This is placebo-subtracted, so the amount of weight loss, these are from the older medications from that time, so phentermine, topiramate, liraglutide, so this is Qsymia, liraglutide 3, Saxenda, naltrexone, bupropion, which is called Contrave, lorcaserin, Belviq, withdrawn from the market, Orlistat has 2 name brands, phentermine, generic, but has a few name brands. So this was in the 5 to 10% total body weight loss in the 1-year mark. It's subtracted from placebo because we wanted to know what was attributed to lifestyle interventions. Okay. This was what our standard was before. That's not what I'm talking about in this talk. While those medications are great and can help people lose and keep off 5 to 10% of their body weight long term, this is long term. This is not I took something for 3 months, I lost weight, and then I was able to stop that medication and keep it off. But I'm really going to talk about the high efficacy medications, because that's when we start to really think about outcomes compared to bariatric surgery. So I'm going to talk about the GLPs, as well as the one GLP-GIP. So these are gut hormones secreted by enteroendocrine cells in response to nutrients are consumed. Semaglutide is GLP, tirzepatide is a single molecule that activates both GIP and GLP. Then they have these downstream effects on other organs. We've heard all morning, and we'll continue to hear, I'm sure Julio's entire talk is going to be about GLPs, is it? No, spoiler alert. No. Okay. We talked about effects on the kidney. We talked about effects on the heart, inflammation. I have patients who have inflammatory disease, inflammatory bowel disease, arthritis types, lupus. That improves with these medications. We know about the weight loss. We know about the lowering of A1C, but so many organs have GLP receptors and are affected by this class of medication. I am going to be inclusive, so I put all the brand names, okay? As a reminder, all of these medications here under brand name that are not highlighted are only FDA approved for diabetes. The 3 GLP medications that are approved for weight loss, treatment of obesity, are highlighted in yellow. And I don't know why this is so confusing to so many people, but there seems to be, I'm like, I don't want to be on Ozempic, a patient will say to me, but I do want to be on Wegovy. And I'm just like, oh God, I don't have enough time in this 15-minute appointment to explain all of this. But at some point, I think people will get it, but I want to make sure that you guys get it because you are the ones out there educating patients on the differences between all these medications, okay? Now, a lot of times patients say, I don't want to go on these medications because they're so new. They're new to social media and Hollywood and Elon Musk and the Kardashians, fine. They're not new to the medical field, right? Like 2005, we had twice daily Byetta. 2010, we had liraglutide, and you heard all about these huge cardiovascular outcome trials. So these are actually like super well studied because they can pool all these huge studies and look at tens of thousands, hundreds maybe, of patients that were in participants in clinical research, okay? So yes, you can see tirzepatide was just approved in 2022, but we've been using semaglutide under the name of Ozempic since 2017. So how much weight loss are we talking? This is from step 1, so this is in semaglutide 2.4. Only Wegovy goes up to 2.4. Ozempic stops at 2, okay? I'm saying these brand names because without saying them, it would be really difficult to understand what I'm talking about. So this was in patients that did not have diabetes but had obesity. And you can see the average weight loss on the maximum dose at 68 weeks of the trial was about 16%. And what you can look at is what percentage of people were actually reaching these really important goals that really help reduce metabolic risk and disease. So 86% of people that were in the trial lost more than 5% of their body weight. 32%, almost a third of patients lost more than 20% of their body weight, which is amazing. And those numbers are higher in the on-treatment group, which is people who were able to tolerate and ramp up in the medication. So when patients say, what are the likelihoods I'm going to lose X amount of weight, you can tell them the average, but you can also say a third of people without diabetes on this medication lost more than 20%. 7% didn't even lose 5. There are non-responders too, right? We can't forget that. So this is tirzepatide. This is the GLP-GIP combo. This is from SURMOUNT-1, and you can see in a dose-dependent fashion versus placebo the amount of weight loss. And 15 milligrams per week at 72 weeks, the average weight loss was 22.5% total body weight. So if someone is 200 pounds, 20% is 40 pounds of weight loss, okay? And it looks like it's kept off long term, right? It's not just immediately coming back. That is amazing. And you can see in the greater than 25% total body weight on the highest dose, 40% of people lost 25. So that's why a lot of people are saying like, oh, these medications are making bariatric surgery obsolete. Okay, they're not making bariatric surgery obsolete, but you are starting to see numbers at least similar to what you might expect from a sleeve gastrectomy or gastric sleeve. Now, as a reminder, people with type 2 diabetes never lose as much weight in these clinical trials, in any intervention. For whatever reasons, genetics, insulin, they just don't lose as much weight. So when your patients ask you, I'm going to start semaglutide, I'm going to start tirzepatide, how much weight can I expect to lose? Ignore everything I just said, okay? With 15 milligrams of tirzepatide at 40 weeks, someone with type 2 diabetes lost 13% of their body weight. This is not 22. And this is compared to semaglutide 1 milligram. This was before semaglutide 2 milligram was being used in their studies, and that was only 6.7%. So we're not talking these huge numbers in patients with diabetes, so don't be surprised when you start these medications, their numbers improve and they lose a little bit of weight, but they don't lose 50 pounds, okay? I'm going to skip the cardiovascular stuff because I think ad nauseum we've talked about that this morning. But we know that a bunch of GLPs already have cardiovascular improved data. Tirzepatide has not yet published its cardiovascular outcome trial data, but some post hoc analysis of studies that have already been done do show likely improvement. So that's exciting. And then we are now seeing these improvements in cardiovascular outcomes in patients that don't have diabetes. So I think that's something new that we didn't talk about this morning, but that's really exciting. That was published last year. This was using weight loss version of semaglutide or Wegovy in patients that had had a history of heart disease, stroke, or advanced peripheral vascular disease, but did not have diabetes, and it showed an improvement. So now, a few months ago, you might have seen that Medicare is now covering semaglutide under the name of Wegovy. This is the first time Medicare has ever covered a weight loss medication for patients who have had an MI, a stroke, or advanced peripheral vascular disease, which is very exciting. It's opening this window to new therapies with new indications and better insurance coverage. So who should consider medication over surgery? Maybe a lower BMI, lack of comorbid conditions, lack of insurance coverage for surgery, increased age or lower life expectancy. We don't send 80-year-olds for weight loss surgery. Advanced disease like cirrhosis, tobacco use, alcohol use, lack of support for a surgery, which is needed, or the need for medications. Some patients don't want surgery, right? Like I said earlier in my case example, she had a colleague or an aunt who gained all the weight back or had some complication after surgery. I call this the cousin and colleague phenomenon because it's always a cousin or it's always a colleague who had weight loss surgery and had a bad outcome, and then I need to show them all the data showing what the odds of that actually happening. Some have already had surgery. Sometimes you can convert a sleeve to a different type of surgery that's more advanced, that has a more component of malabsorption. Maybe they don't qualify for it. Maybe their insurance, like TRICARE, you can only get one surgery per lifetime with TRICARE insurance. Maybe they don't have a good surgeon, or they don't have access to a surgeon who's skilled in gastric bypass, or maybe their BMI is above 50 and they need to lose weight before having surgery, which can improve their surgical morbidity risk. The pros and cons, how they work, their efficacy, the benefits beyond weight loss, the ease of access. I'm sorry, that's a joke. I don't know why I even put that in there, because getting these medications from the pharmacy, covered by insurance, right now is a full-time job. I often joke that I am a drug dealer. I am a GLP drug dealer, and it's really difficult. I'm joking, but it's not easy to get access, but hopefully that will change. And as these companies are increasing production and opening factories, availability will get better. And I really do think insurance coverage is going to change as they start to realize the cost-saving benefit of disease prevention, okay? And we really don't know of a ton of long-term risks, and they're not invasive. Bad things, contraindications, really allergy or hypersensitivity, can't tolerate it, high cost or lack of insurance, inability to find it, not a responder, severe obesity or patient preference, and I put an asterisk because all of those are modifiable things. If you change your lifestyle, if you start at a lower dose, if insurance changes, if supply changes, all of those things are modifiable, so there's honestly not that many cons that hopefully we can't overcome. What happens when weight loss medications are stopped? This is from step 4, so this is looking at the weight loss version of semaglutide or Wegovy 2.4. SURMOUNT-4 looked at the weight loss version of tirzepatide, also called Zepbound, and found the same thing. If you take a medication, put all the participants on the medication, let them lose weight, and then at some point in time, randomize them and blind them so that they don't know, blind them, but like they don't know if they're going to get placebo or the medication. Continue the study. They're working with dietitians. They're meeting with researchers. They don't know if they're getting the medication or not. Neither does the researcher. The people who continue medication continue to lose weight, and those who stop regain the weight. And some might keep some of the weight off, but long-term, weight comes back because what did we talk about with the set point and how your body adapts to weight loss, right? So let's come back to Heidi. She lost 22 pounds without Ozempic, and I was like, I can't believe this has made mainstream magazines. And then I actually read the article, and you want to hear the best part? It was an advertisement for Hydroxycut. She didn't take Ozempic, but she used Hydroxycut, a non-well-regulated by FDA supplement that does not have good data, that is not prescription but is over-the-counter, which again brings up what I was telling you guys about what patients are saying. They'll take a supplement, but they won't take a prescription, just some barriers, right? So here, you thought she did it naturally, but the joke was on us, right? So let's talk about surgery. I have so little time. There's a lot of surgeries out there. There's a lot of procedures. There are intragastric balloons. The two surgeries I'm going to focus on are a gastric sleeve and a gastric bypass. These are the two most common types of surgeries. The approval is based on FDA. Historically, it's been a BMI of 35 or above with a comorbid condition, and each insurance company has a different list of what is considered an acceptable comorbid condition, just to make this so fun for everybody, or a BMI of above 40 without medical conditions. However, ASMBS, the American Society for Metabolic and Bariatric Surgery, a few years ago, looked at all the existing data, and some of this was done in diabetes, and said, we should consider it down to a lower BMI. We have good data, especially in certain populations that are really high risk, that a BMI of 30 and 35 should be the cutoffs instead. So to make this extra fun, some insurance companies have adopted the new recommendation. So if you guys work for Scripps, the Scripps EPO health plan, cutoffs are 35 and 40. The Scripps HMO health plan, the cutoff is 30 and 35. So if you guys are confused and don't know what to tell your patients, I get it. This is a full-time job, right? I'm not even going to say it again. ADA did studies, the Stampede trial that I'll talk about briefly, that looked at patients with really lower BMIs than you would expect, even recommending down to a BMI of 27.5, because in some of these trials, it was shown that if you have metabolic syndrome and central adiposity and diabetes and high blood pressure, all the risk factors for cardiovascular disease, even at a lower BMI, you can benefit. So this also pertains to that question about how you approach diabetes in someone lean versus not lean. So it's confusing. Here are the two different types of surgeries. This is normal anatomy. This is a gastric sleeve, where they're basically removing 70 to 80% of the stomach. The stomach makes ghrelin. That's your hunger hormone. So by removing that, that can help with appetite, but there's other things it can do. It makes a small stomach, so it's restrictive. You get full faster. Gastric bypass. Oh, by the way, the stomach is removed after the sleeve. In a gastric bypass, all the parts remain in your body, and for some reason, patients like that better, because hypothetically, in an emergency situation, you could reverse it. But that is complicated, and we don't want to go around reversing these types of surgeries, but hypothetically, you could. So that is one way in which I try to convince patients to do a bypass over sleeve. So you have restriction because the stomach is made small. It's made into this small pouch. But you're actually rerouting the intestines, where you are bypassing this part of the stomach and the beginning of the small intestines, duodenum, and you are then depositing food directly into the later part of the intestines. So not only is it restrictive, but you're not absorbing all of the nutrients that used to be absorbed, so less calorie absorption, but also less nutrient absorption, depending on the nutrients, and more risk of nutrient deficiencies, like low vitamin D, calcium, iron type stuff. The way surgery works is multifactorial, and I'm not going to get into too much detail, but when we talk about these injectable medications, these GLP agonists, as a reminder, these are things that your body makes in response to food intake. And when you have a gastric bypass, directly into the small intestines, you're depositing undigested food particles. So your intestine will make its own, the enteroendocrine cells will make its own GLP. So actually, after a gastric bypass, at least in the short term, your own production of GLP goes really high. So it's basically, in some ways, like taking a medication, and usually why I hold those medications right after surgery and wait and see how people do. Short-term weight loss with bariatric surgery. Bariatric surgery is still the most effective treatment for obesity in terms of both durable weight loss and improvement and remission of other diseases. The average weight loss with bariatric surgery is about 33%. It'd be a little bit on the lower end for someone with a sleeve with a higher risk of weight regain, so we're talking maybe 25 to 30%. Someone with gastric bypass could be 35 to 40%. So as an example, someone who starts out at a weight of 250 and loses 33% would get down to 168 and hopefully maintain that weight long term. Usually their weight reaches its lowest point between 12 to 24 months after surgery. And there's a lot of hormonal changes. It's not just your stomach's really small, but you're just as hungry. I have a lot of patients who think that's what happens. And they're like, but I'm going to have these urges to eat, but I won't be able to. No, you're basically taking a weight loss medication in some ways, because either your ghrelin or your GLP or your PYY, like all these different things are changing, at least in the short term, in the first 1 to 2 years after surgery. The reduction of comorbid conditions after bariatric surgery is unprecedented compared to anything, and that is because all of these medical conditions are rooted in obesity, or can be improved with treatment of obesity, which we've heard about all morning, and the reduction in risk of high blood pressure, diabetes, without the addition of medications, but taking away medication is just unprecedented. Patients are often saying, I wish I did this sooner, not I wish I didn't do this. Mortality decrease is also really important. So one of the best kind of studies, publications that we have is this Swedish study that was prospective, controlled in about 4,000 subjects with obesity. Person first language again, I messed that up. And it was basically looking over time at amount of weight loss, and you can see, right, Diana's worried that she's going to regain it all weight because she had a cousin who regained all the weight. And yes, you know, at 1 to 2 years, they reach their lowest point and might regain some weight, but this is 15 years out, and of the people that were still in that study, you can see that there was still down 25% after gastric bypass. Show me a patient who's lost weight with diet and exercise 25 or 30% of their weight and kept it off for 15 years. People magazine, I want their next edition to be half their size 15 years later. I'm literally going to email People magazine and tell them that. Okay, bariatric surgery versus medical therapy. This was the Stampede trial done at the Cleveland Clinic, and this was looking at the treatment of diabetes, right? It used to be a bariatric surgery organization. They changed the name to ASMBS, Metabolic and Bariatric Surgery, because it's not just weight loss, right? By losing weight, you are improving all these other medical conditions. This was done before the really high efficacy GLPs were done, but it just showed improvement in A1C and with weight loss while getting off of medications, more likely to get diabetes remission. Bariatric surgery is not without risk, right? So I have 2 different tables from different publications showing you the approximate risks, and this one on the left is grouping all the different bariatric surgeries together, including revisions and a lap band and duodenal switch, bypass, sleeve. So I don't think it's super accurate. Some of these numbers, like in the leak, might be overinflated. Our surgeons at the Scripps Clinic said that it's probably closer to 0.3 or 0.4%. So these are low percentages, and I've seen tables comparing bariatric surgery to gallbladder removal or even hysterectomies. So we're not talking, and it depends which surgery. Gastric bypass is more involved. And on the right, you can see that the risk of complications is also surgeon dependent. So they interviewed peers of surgeons and then basically put the surgeons into quartiles based on what their peers felt their skill was. And you can see in the 4th quartile, so the highest level of skill, the odds of complications was lower, and it was more significant for obstruction, infection, renal disease, pulmonary complications, and death. Okay? So you don't just want to go to a surgeon, you want to go to someone that everyone else is recommending you go to, a skilled, an esteemed one who has good outcomes, and outcomes are public information for surgeons. Mortality also improves after surgery, okay? This is also from that Swedish study. You can see just a few years after surgery, your odds of being alive are more likely if you had had surgery than didn't have surgery. And I have printouts of this, of all of these things in my office that I'm showing to patients because I feel like I'm having to convince them to do medications or bariatric surgery. But it turns out I have to convince all of you guys too, so this is fun. So don't rule out surgery just because it's invasive, right? It is invasive, though. There is a risk. We do it laparoscopically, really, though, so it's not as invasive. There's a risk of complications. You need to take supplements, probably cheaper because it's a one-time cost. $1,000 a month medication that you need to take for the rest of your life for a 24-year-old is different than if you're 80 years old, right? And then there's always a risk of weight regain. About 1/3 of patients will regain more than 25%. This is even more for a gastric sleeve. I'm not a huge sleeve fan, but I think gastric bypass is one of the most underutilized tools that we have in all of medicine. So I hope that you guys start to think more about it as well as these weight loss medications. I'm going to go quickly. The truth is this is what the future might look like, right? A gastric sleeve with a GLP later on, so a surgery, and then when they start to increase, adding a weight loss medication to help them either maintain their weight or resume weight loss. And this was a study that was done in Japan. It was people who had a gastric sleeve, which is not as potent, doesn't increase endogenous GLP as much as a gastric bypass, but it's an easier surgery with lower risk of complications, depending on the surgeon, and then adding semaglutide later on. So it's not surgery versus medication. The truth is it's a hybrid of them both. We need more studies, though, because these really high efficacy medications, like tirzepatide, were just approved. We need more randomized controlled trials. So let's go back. okay? Diana's 44. I don't know how people have answered this already, but it looks like you guys have already started. Oh, you guys have changed your minds. Wow, okay, so now 4% would consider bariatric surgery, up from 0%. Woo! That's success. 2% said an anti-obesity medication like phentermine or phentermine topiramate. 5% said metformin still, which I didn't talk at all about, but that's cool. Okay, 10% surgery. 17%, so it used to be almost half of you said have her do more diet and exercise, but that's gone down. And then all the way at the top, at 68%, is an anti-obesity such as semaglutide. Guys, she's got the Scripps HMO. The Scripps HMO doesn't cover weight loss medications. She's going to have to pay $650 a month out of pocket for the rest of her life until pharma and PBMs can get their stuff together. Is that what we're going to? Maybe. Maybe we got to figure out crafty ways to make it lower cost or make it more affordable, or maybe she has unlimited expenses and can be on whatever. Oh, now there's more. I see. Right when I said that, bariatric surgery went up to 20%. Guys, her BMI is above 35 with hypertension. ASMBS says consider bariatric surgery for a BMI above 30 with a You guys, this is like beyond what I even expected. BMI above 30 with a comorbid condition requiring treatment. Those are usually high blood pressure, high cholesterol, sleep apnea, heartburn, and diabetes. Okay, 50-30, you guys. You guys are so convincible. Okay, so I just want you to think, how would your answer be different based on all these things? And hopefully I touched on some of these nuances, right? Someone who's suffered with obesity since childhood, really, and they've yo-yo dieted their way up to 300 pounds, and we're going to tell them meet with a dietitian and exercise more, that they've spent their entire lives doing that, you guys. We can do better. We can do better, okay? I'm going to skip ahead. They're not mutually exclusive. Treatment of obesity is much as an art and as a science. I told you guys I'm a drug dealer. This is my menu when patients come to clinic. I say this is the average % of weight loss from these different interventions. They're not mutually exclusive. We can use them together, but here's how much you can expect. And remember, for people with diabetes, these numbers are always lower, okay? I am fortunate that I get to work at a multidisciplinary clinic, and there's a couple doctors missing, but you can see Dr. Fujioka is about to talk. Here is... this is Mark Takata, this is Will Fuller. So we also have 2 surgeons, right? We have dietitians, we have a health coach. It's a multidisciplinary clinic because obesity treatment needs all hands on deck. That's it.